Yeah, sure. Shall I start then?
Recording in progress.
Yeah? Ready? Yeah. All right. Hi everyone, welcome to the RRI series, the YouTube series on StudyMEDIC Part 2. And today's topic is from the early pregnancy module, and we'll be discussing on the topic recurrent pregnancy loss, which is based on the S3 guidelines. So recurrent pregnancy loss is one of the most important topic, which is a favorite topic for Part 2 MRCOG examination, where they can ask questions from the definition onwards, the risk factors of so many percentages. They can ask questions about investigations as well as the management. So this was the S3 guidelines on recurrent pregnancy loss was last updated in 2022. So we'll start with the definition. So before going to recurrent pregnancy loss, just to give a brief idea of what is miscarriage or pregnancy loss, that is a spontaneous demise of a pregnancy before the fetus reaches a viability from the time of conception, and it is taken up to a cutoff period of 24 weeks of gestation. And how do we diagnose a miscarriage? The miscarriage can either be a missed miscarriage or like a complete miscarriage, incomplete or inevitable miscarriage. And we need to diagnose a missed miscarriage either based on the CRL criteria or a gestational sac criteria, which is all given in detail in the NICE guidelines, which tells us that the missed miscarriage can be diagnosed if 2 times it is confirmed that there is no fetal cardiac activity, if the CRL is more than or equal to 7 millimeter, and based on the gestational sac mean sac diameter criteria, when the mean sac diameter is more than or equal to 25 millimeters, still if there is no fetal pore or yolk sac, then it is confirmed 2 times, we can diagnose it as a case of missed miscarriage. So that is pregnancy loss. According to the UK guidelines, it is taken up to a cutoff of around 24 weeks of gestation. Now, what is recurrent pregnancy loss? So S3 guidelines have stated is that the recurrent pregnancy loss is after 2 or more pregnancy losses. Now, it can either be classified into primary recurrent pregnancy loss or secondary RPL. Primary RPL means without any previous ongoing pregnancy which was viable and more than within 24 weeks of gestation, while secondary RPL means there was a viable pregnancy. It may be a viable live birth or may not be a live birth, but definitely that was a viable pregnancy which has progressed beyond 24 weeks of gestation, and then an episode of RPL after 1 or more of previous pregnancies. Recurrent pregnancy loss for S3 is based after 2 or more pregnancy losses. Now, how do we diagnose that there was a pregnancy? Because we are confused many times with whether it should be concluded as a pregnancy was there or just it was some hormonal variations which we call as a biochemical pregnancy. So it all depends upon the evidence. So the pregnancy in the definition can be confirmed. At least there should be presence of serum beta-HCG positive for pregnancy or urine beta-HCG. And that is including non-pregnancy losses like biochemical pregnancy losses and or resolved and treated pregnancies of unknown conditions. So the pregnancy losses can be divided into 2 types. Like with this, one is visualized pregnancy loss, other is non-visualized pregnancy loss. What is visualized pregnancy loss? So once the periods are missed, we do the urine pregnancy test. It was found to be positive and an early pregnancy scan was done, which confirmed a viable intrauterine gestation. So live intrauterine gestation was confirmed, or intrauterine pregnancy, at least with the presence of yolk sac and a gestational sac was confirmed. And later on, it unfortunately ended up in a pregnancy loss. While non-visualized pregnancy loss means beta-HCG was positive, and it was more than 6 weeks of gestation, but it was followed up with an ultrasound later on when suspected for pregnancy loss, which showed no evidence of intrauterine products of conception, intrauterine gestational sac or yolk sac or fetal pole or cardiac activity, which means if the scan had been done earlier than the miscarriage period, if the scan was done early in pregnancy, there would have been the presence of intrauterine gestation with the presence of intrauterine gestational sac, the yolk sac, fetal pole, or cardiac activity. So that is something called as visualized pregnancy loss. So that is why both non-visualized pregnancy loss and visualized pregnancy loss both can be taken as a pregnancy loss. Now, there are certain conditions like beta HCG will be positive, but there is no intrauterine normal pregnancy, like ectopic pregnancy, molar pregnancies, and those should not be included in the definition of a miscarriage or pregnancy loss. Also, implantation failure should not be included in the definition of pregnancy loss. And the pregnancy losses which occur after a spontaneous conception or after an ART treatment, both can be included in the definition of pregnancy loss. So it's just clear that urine beta HCG or serum beta HCG is positive, and if there is a presence of intrauterine gestation confirmed in the scan, or if it had been done early in pregnancy, there would have been presence of intrauterine sonographic evidence of gestation. Alright, so there is something called recurrent early pregnancy loss, which means it has the recurrent pregnancy loss of more than 2 or more pregnancies has occurred less than 10 weeks of gestation. And earlier we used to use the terms like chemical pregnancy, blighted ovum, spontaneous abortion. All these are ambiguous and the terminologies have to be avoided. Now the terminology is a miscarriage instead of abortion, and we no more use the blighted ovum. Blighted ovum is nothing but the presence of gestational sac but no fetal pole, but that itself is concluded or coming under the category of miscarriage. If the gestational sac is more than 25 millimeters, still no evidence of yolk sac or fetal pole, it can be taken as an embryonic pregnancy or miscarriage. Now, the pregnancy loss definitely will affect the cause a negative life event, and the repetitive nature of the recurrent pregnancy loss can intensify the grief experience, and so definitely they need a psychosocial support. And there are certain centers which give the RPL clinic centers with emotional as well as other support also. What are the risk factors? So in the reproductive age group women, the lowest risk of pregnancy loss is between 20 to 35 years of age group, and as they increase in the maternal age, more than 35 years, especially after 40 years, there is a rapid increase in the risk of pregnancy loss, almost 90 to 95% after 40 years of age. And stress was found to be associated with pregnancy loss, but couples should be informed that there is no evidence that stress has got a direct link with the cause of pregnancy loss. And smoking overall, it cause adverse effects on the health of the pregnant woman, not even in pregnancy, outside pregnancy also. And so it has got adverse effects on the pregnancy outcome and perinatal outcome. As a result, we need to advise them for cessation of smoking. About the weight, ideal maternal BMI should be maintained prior to conception, and maternal obesity and significant underweight was found to be associated with many pregnancy complications, and that can decrease the live birth rate. Overall, it can affect adversely the general health and well-being of the woman. So it's always important to maintain the normal body mass index. So maternal obesity was found to be a risk factor for recurrent pregnancy loss with direct association. And when there is a weight loss in overweight women, it improved the pregnancy outcome as well as the fertility outcome and helps to reduce the complications during pregnancy and childbirth. What about excessive alcohol consumption? It's a possible risk factor, and more than its effect on the recurrent pregnancy loss, it causes the fetal alcohol syndrome. So about the fetal alcohol syndrome, it has got several structural defects and cognitive impairment, and alcohol consumption was not found to have a causal association, but overall it reduces the pregnancy outcome. And there is no limit or lower limit for alcohol consumption. It is always advisable if they can avoid alcohol consumption during pregnancy. So coming to about the investigation, what are the investigations which we need to do while we start for the workup of a recurrent pregnancy loss? So starting from the history onwards, which contribute to the workup of recurrent pregnancy loss, we need to ask thorough medical history as well as family history. About the medical history, we can ask whether there were any family history of any repeated stillbirths or congenital abnormalities or structural abnormalities or any genetic disorders. as well as any family personal history of venous thromboembolism or any comorbid conditions, especially if it is uncontrolled or not in remission at the time of conception, like uncontrolled diabetes mellitus, uncontrolled thyroid disorders, uncontrolled connective tissue disorders like SLE or rheumatoid arthritis or chronic renal disease or any chronic hypertension. All this, if it is not in remission or not in optimal control prior to conception, can have an adverse effect on the pregnancy outcome, causing pregnancy loss. And regarding the family history, we can elicit the history about any family history of thrombophilia, acquired or hereditary thrombophilia, or any family history of thromboembolism, or any other previous history of recurrent stillbirths or congenital disorders can be asked for. So there have been different prognosticated models which have come forward to prognosticate and predict the success of the live birth rate outcome of the present pregnancy after previous recurrent pregnancy loss. And the main things which are focused on are the woman's age and her pregnancy history, including the number of previous pregnancy losses, live births, and their sequence. So maternal age and pregnancy history, these are the two important prognostic factors which can predict further success rate of in a woman with recurrent pregnancy loss. As maternal age, we already mentioned, the risk of having a pregnancy loss rapidly shoots after 40 years of age, almost more than 90%. And about the pregnancy loss, as the number of pregnancy loss increases, the risk of having more and more pregnancy losses is increased. As the number of live births are more, at least one live birth, the chance of reducing the pregnancy loss has been increased. So that doesn't mean that if there is a recurrent pregnancy loss, the chance of having a live birth and a viable pregnancy in a subsequent pregnancy is almost nil. After 3 or more pregnancy losses, it also, if in spite of not finding out the cause and not treating the cause, like in case of unexplained recurrent pregnancy loss, it has been found that almost 75% chance of having a successful live birth with just supportive management, emotional support, and tender loving care. And the number of preceding pregnancy losses and female age, they are the best available prognostic factors to predict the future outcome. Now coming to about the workup, starting with the investigations, starting with the chromosomal abnormalities. As we all know, the most important causes of a recurrent pregnancy loss starting are like from almost like 50% cases are even after an extensive workup, we won't be able to find out the cause for that, but which can be classified as unexplained pregnancy loss. Then comes the genetic causes. So the genetic causes can be chromosomal abnormalities, which are more of structural abnormalities than numerical abnormalities. The structural abnormalities mainly due to the translocation from a balanced translocation of the parent, resulting in unbalanced translocation of the offspring if both parents are affected with a balanced translocation, resulting in stillbirth, structural abnormalities, and recurrent pregnancy loss. And also it could be contributed by deletions, inversions, and duplications. So in that case, we would recommend for the workup of the genetic analysis of the pregnancy tissue, that is products of conception, from the third pregnancy loss and for the further pregnancy losses onwards. In case if it is in the first trimester, and if it is in the second trimester, even with one second trimester pregnancy loss, it is indicated to perform the genetic analysis of the pregnancy tissue. So, but genetic analysis of pregnancy tissue is not routinely recommended, as it has got only explanatory purposes, and the genetic study is done by the recommended method is by the array comparative genomic hybridization, as it helps to reduce the maternal contamination effect by mixing up of the maternal cells when compared to the conventional culture method or the karyotyping method. So once we see there is an abnormality in the karyotyping or the chromosomal study of the product of conception or the pregnancy loss tissue, then the next step is to do the parental peripheral blood karyotyping, mainly by the G-banding study. And that should be carried out after individual assessment of the risk for the diagnostic or explanatory purposes. And always to be kept in mind and to convey to the couple is that even if there is a parental abnormality found, the cumulative live birth rates are really good. So if there is a parental abnormality found in the karyotyping, then the next step is to refer them for a genetic counseling and not direct them straight for an intravenous IVF or in vitro fertilization with the pre-implantation genetic diagnosis, but we have to direct them directly for a genetic counseling, and then give them different options. That the different options can try for a natural birth. As I already mentioned, the cumulative live birth rates are good. If it is for example, if it's a case of translocation of 21-21, there is almost 100% risk of recurrence in the subsequent pregnancy. But otherwise, the risk of recurrence in other case of translocation, it varies, and it could be anywhere between 50% to 75%. So there's still a chance of having a live birth rate. And always, when compared to IVF, natural conception and natural birth have got a higher success rate. So it is always better to give them options. They can continue for a natural live birth, or they can try the IVF with a pre-implantation genetic diagnosis and then remove the embryos which has been affected with the unbalanced translocation, gamete donation, adoption. These are the different options available. And they should be informed of the limitations of the karyotyping and impact of the test result. Now coming to about the next one, which is the hereditary thrombophilia. So the hereditary thrombophilia workup is not routinely recommended in all women with a pregnancy loss, especially if they have got a recurrent first trimester pregnancy loss. If they have got any risk factors or any other clinical features of a thrombophilia, like history of thrombosis, thromboembolism, personal history or family history of thromboembolism, or a family history of thrombophilia, like these are the additional risk factors for thrombophilia. In those cases, then if there is a context of recurrent pregnancy loss, it is indicated to do the workup. Otherwise, it is done only in the context of research. Now, coming to about the acquired thrombophilia, that's the antiphospholipid antibodies. By doing lupus anticoagulant, anticardiolipin antibodies. And so we all know that antiphospholipid antibody syndrome is diagnosed by the revised Sapporo criteria, and that still holds good even now also. So for revised Sapporo criteria, we need at least one clinical criteria, and along with that, one laboratory criteria. Clinical criteria mentions recurrent pregnancy loss, which is 3 or more early recurrent pregnancy loss less than 10 weeks of gestation, and more than 10 weeks of gestation, at least one, but it should be normal, morphologically normal fetus with all other causes have been excluded, and resulting in a preterm birth less than 34 weeks of gestation because of some uteroplasmal insufficiency like preeclampsia, severe eclampsia, oligamious abruption. That if any of these is satisfied, then it satisfies one clinical criteria. And then the laboratory criteria should include 3 antiphospholipid antibodies, that is lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. So the lupus anticoagulant and anticardiolipin antibodies are offered, means they are to be screened after 2 pregnancy losses according to the ASHRAE guidelines. And we do the lupus anticoagulant. There are different tests available: dilute, Russell Viper venom test, or the prolonged prothrombin time. And for ACL, that is anticardiolipin antibodies, we have to do the ACA, IgG and IgM, and we look for the titers. While beta-2 glycoprotein antibody can be considered to be screened after 2 pregnancy loss, as it is more specific for a thrombosis risk rather than a pregnancy morbidity. So the antiphospholipid antibodies will provide a possible cause for the pregnancy loss, and the treatment in the next pregnancy has been found to there is evidence that it can prevent the antiphospholipid antibody syndrome associated pregnancy complications. So how do we treat them? We will discuss in a minute. But definitely the treated cases of antiphospholipid antibody syndrome has found to improve the pregnancy outcome and live birth rate when not treated. Also, it helps to reduce the thrombotic morbidity. So when I mentioned about the clinical criteria, I mentioned about the pregnancy criteria. So either it can be pregnancy morbidity or a thrombotic morbidity. If any of these are present, then it can be taken as one clinical criteria, and one clinical criteria along with one laboratory criteria has to be done. And these investigations have to be repeated if found to be positive in the first instance at least 12 weeks apart, to be done at least on 2 occasions and 12 weeks apart, and both times it should be positive. Then only we can take that laboratory criteria is present along with clinical criteria is also present. Then we can classify it as or give a diagnosis of antiphospholipid antibody syndrome. So if only clinical criteria is not there, only laboratory criteria is present, then we can take it as only anti-phospholipid antibodies positive. Now, the next one is the HLA or the human leukocyte antigen determination in women with recurrent pregnancy loss. It is not recommended. It is recommended only in Scandinavian women after secondary recurrent pregnancy loss after birth of a baby boy. That too only for prognostic purposes. Now, what about the anti-nuclear antibody testing with immunofluorescence? It is concerned only for explanatory purposes. So, coming to about the connective tissue disorders and the autoimmune disorders and its effect or impact in recurrent pregnancy loss. So, as such, if in all these connective tissue disorders like SLA, Sjogren's syndrome, rheumatoid arthritis, and all those vasculitic disorders, if they are in remission and they are actually controlled at the time of conception, they as such will not result or cause a pregnancy loss or a recurrent pregnancy loss, unless in one case where SLE is associated with secondary antiphospholipid antibody syndrome. While if it is not screened at all, but the woman with a recurrent pregnancy loss have got clinical features which are suggestive of any of these autoimmune disorders, then we are justified to do the anti-nuclear antibody immunofluorescence testing as a screening, and if it is found to be positive, can do the further profile to see whether it is SLE, Sjogren's, and whether anti-ROL antibodies are present, and further antibody workup can be done. Coming to about the thyroid disorders, thyroid screening. So it is recommended to do thyroid stimulating hormone TSH and thyroid peroxidase antibodies, TPO antibodies in women with recurrent pregnancy loss. So it is based on the evidence that there is a high prevalence where the subclinical hypothyroidism women and they have got thyroid autoimmunity, and this together comes more in prevalence in women with the recurrent pregnancy loss, and there is a potential of treatment options are available for thyroid functions which helps to improve the pregnancy outcome. Hence, this TSH and anti-TPO antibody testing is recommended for all women with recurrent pregnancy loss. So when there is an abnormal TSH level, then it should be followed by a T4 testing or thyroxine testing in women with RPL. Next, what should be done about the uterine malformations? Do they have a role in recurrent pregnancy loss? Yes, there are certain uterine malformations which can cause recurrent pregnancy loss, and the most common cause is septate uterus, more in the second trimester, also in the first trimester. So all women with recurrent pregnancy loss should have an assessment of the uterine anatomy, and this should be based on the association and impact of the treatment decisions. So how do we work up for the uterine anatomy? So we ideally, the recommended method is to do a 3D transvaginal ultrasonogram. It has got very high sensitivity and specificity, and it can even distinguish between the septate uterus and bicorporeal uterus with a normal cervix, because as we know, it's very closely associated and very difficult to differentiate condition in an ultrasound scan, but even transvaginal 3D ultrasound can differentiate these two, as the management have got a different management for both these conditions. So sonohystrography, which is SHG, is more accurate than HSG, which is hysterosalpingography, in diagnosing the uterine malformations. So can be used to evaluate the uterine morphology when the 3D ultrasound is not available, or when we need to investigate, or when there is a subfertility factor evaluation also to be done, for the tubal factor patency to be done. We can combine the SHG or the HSG instead of the 3D ultrasound. Now, if we find a uterine malformation by the 3D ultrasound, then we need to do the complete evaluation of the woman by working up on the renal tract as well as the skeletal system, because they have got a common origin for all these structures. Do we need to do MRI in all women with uterine malformation and recurrent pregnancy loss? Not recommended as a first-line option, because if we have got a satisfied thorough 3D transvaginal ultrasonogram is done by an experienced personnel, and it has been diagnosed, the uterine malformation, and there is no doubt of it, no need to do an MRI. Only in conditions where there is no experienced personnel or facilities to do the 3D ultrasound, we need to do the MRI for interpretation. And all women in recurrent pregnancy loss could have been offered with a 2D ultrasound to rule out adenomyosis, as there has been some studies which shows that there can be some link between adenomyosis and pregnancy loss. while there are no major RCTs available. Coming to about the male factors. So the male factors which we need to talk about while we do a thorough history and evaluation is we have to ask about the paternal age. Like the maternal age, the paternal age also has got some impact on the pregnancy loss, smoking, alcohol consumption, exercise pattern, as well as a body weight. These are the things of the lifestyle of the male partner which needs to be assessed. And what about the semen analysis? The semen analysis also, certain factors have got an impact on the pregnancy loss. Of this, the most important one is the sperm DNA fragmentation. So, assessing the sperm DNA fragmentation in couples with recurrent pregnancy loss could be considered for diagnostic purposes, as there are evidence which shows there is an association between the poor quality of the semen and recurrent pregnancy loss, particularly the sperms with elevated sperm DNA fragmentation. So, that could be used for diagnostic purposes. So definitely all these investigations are to be done, but the following investigations are not recommended for workup of a recurrent pregnancy loss, in spite of we diagnosing it as an unexplained recurrent pregnancy loss also, like anti-HY antibodies, cytokine testing, cytokine polymorphisms, natural killer cell testing of peripheral blood or endometrial tissue, anti-HLA antibodies, assessment of the polycystic ovarian syndrome by using fasting insulin and glucose in women with an RPL to improve the next pregnancy prognosis. Prolactin testing, it is indicated only if they have got a clinical features of a hyperprolactinemia like oligomenorrhea, albinuria or galacturia, but otherwise it is not indicated if no clinical symptoms. Ovarian reserve testing, definitely not indicated for a workup of recurrent pregnancy loss. Luteal phase insufficiency testing, earlier we used to think that LPD or luteal phase defect plays a role in recurrent pregnancy loss, but there is no evidence, and that is why even in unexplained recurrent pregnancy loss, we don't recommend the use of progesterone. Androgen testing is not recommended. LH testing, homocysteine plasma levels not recommended, and MRI is not recommended as a first line option for the assessing uterine malformations. Now coming to about the management part. As in general, for all women, not only for those who have suffered the recurrent pregnancy loss or pregnancy loss, for all pregnant women, periconceptual as well as preconceptual counseling is very important in women, and especially in recurrent pregnancy loss, they need a preconceptual counseling and needs, if not evaluated or workup is not done prior, they need a thorough evaluation and workup prior to getting pregnant, as some of the investigations doesn't give a correct value or accurate value during pregnancy. And we need to give a general advice for the optimal management of the hygiene as well as optimal control of the comorbid condition. Any infections to be treated, anemia can be managed, or also other conditions like antiphospholipids and antibody syndrome, we need to start on aspirin preconceptually. Along with that, we can advise them to start the prophylactic vitamin D supplementation, as it has been shown that there would be some benefit in those women with recurrent pregnancy loss. Now, the significant prevalence of vitamin D deficiency in women with recurrent pregnancy loss and possibly associated obstetric and fetal complications, prescribing vitamin D supplementation can be considered, though the complete effectiveness is not available, as it is not harmful, means vitamin D supplementation is considered safe in pregnancy. It can be given. And definitely low dose folic acid, 400 micrograms daily, has to be given preconceptionally at least 3 months prior to prevent the neural tube defects. And those with high risk of neural tube defects have to be treated or given supplemented with high dose folic acid, 5 milligrams daily. Those like with the history of overt diabetes mellitus type 1 or type 2, those on antifolate medications or anti-epileptic medications, previous history of neural tube defects, obesity, all these individuals need to be given high dose folic acid of 5 milligrams per day. Now, as I've already mentioned, there are certain prognostic tools which has been put forward to provide an estimate of the subsequent chance of live birth in couples in recurrent pregnancy loss. Those are called Vesicard, though it is not widely used in clinical practice, but these are available for research purposes mainly. And about the karyotypic abnormality, if we find any abnormality of the karyotype, as I've mentioned in the product of conception or the pregnancy loss tissue, we need to do the complete karyotyping of the parent and then refer them for the genetic counseling. So the treatment of women with subclinical hypothyroidism may reduce the risk of miscarriage, but the potential benefit of treatment should be balanced against the risk. So the next important one, almost 10 to 15% of cases of recurrent pregnancy loss is contributed by the antiphospholipid antibody syndrome. And it should be understood that if it is not treated with any of the medications, the live birth rate is only just 10 to 15%. While APS, if it is treated with aspirin alone, we can increase the live birth rate to almost 30 to 40%. And if we combine low-dose aspirin and low molecular weight heparin for the management of APS, then the live birth rate can still be increased up to 80% of the cases. So, how should we manage this? By administering low-dose aspirin, which is 75 to 100 milligrams daily. Ideally, it should be started before conception, and a prophylactic dose of heparin, either unfractionated heparin or low molecular weight heparin, can be started from the date of the starting at the date of urine pregnancy test positive, rather than giving no treatment, because it is proven to have beneficial effects and prevent the pregnancy loss, but though it's not 100%. And anticoagulant treatment for those women without satisfying the clinical criteria is only in the context of clinical research. So the cervical insufficiency in cerclage and the role of progesterone, that itself is a whole major topic, and there are separate guidelines. It is beyond the scope of this short YouTube series, but for a completion's sake, those women with a history of second trimester pregnancy losses or a suspected cervical insufficiency should be offered serial cervical length sonographic surveillance by transvaginal scan ideally. And if it is found less than 24 weeks of gestation, if the cervical length is found to be less than 24 millimeter, or if there is an opening or a funneling of O's, then it is an indication to do ultrasound indicated cerclage. Or if it is just shortening of the cervix, then even progesterone could be considered. So in women with singleton pregnancy and a history of recurrent second trimester pregnancy loss, which is attributable to cervical weakness, a cerclage could be considered, though there is no evidence that this will definitely improve the perinatal survival and outcome. Always to be borne in mind that all second trimester pregnancy losses are not because of any cervical insufficiency or cervical weakness, and that it will benefit from a cerclage. So that's the importance of doing a thorough history and also evaluation, that even the thrombophilias, hereditary thrombophilia, acquired thrombophilia, uterine malformation, all this can also contribute to second trimester pregnancy loss. So if we do cerclage in those which is not because of a typical history of previous cervical weakness, then they will not get benefit if we do a cerclage unnecessarily. Thyroid disorders, overt hypothyroidism is definitely found to have an association with causing pregnancy loss. Those which arise before conception or during early gestation, they need to be treated with levothyroxine in women with recurrent pregnancy loss. And those women, if they have got subclinical hypothyroidism and recurrent pregnancy loss, and in the present pregnancy, if they are pregnant again, then they need to be checked with a thyroid stimulating hormone. The TSH should be done at early pregnancy, around 7 to 9 weeks of gestation. And if there is a hypothyroidism identified, that need to be treated with levothyroxine, even if it is a subclinical hypothyroidism with RPL, because there has been some legal association associated with subclinical hypothyroidism and RPL. So in those women with thyroid autoimmunity and RPL, they are pregnant again. TSH again has to be checked early in pregnancy between 7 to 9 weeks of gestation, and hypothyroidism, if it is there, should be treated with levothyroxine. If they are euthyroid women with thyroid antibodies, and they have got RPL, then they need not be treated with levothyroxine. No need to treat them with levothyroxine if they are euthyroid. So the levothyroxine treatment does not increase the chance of a live birth in women with a history of RPL and thyroid immunity if they have got normal TSH and anti-TPO antibodies. About the overt hyperthyroidism, thyrotoxicosis, ideally they need to be in optimal control prior to conception. So as I've already mentioned, importance of cessation of smoking and limiting alcohol consumption to maintain a normal body weight and BMI prior to conception, normal exercise pattern to be maintained is all recommended. This is an update which has come in the 2022 edition of the ESHRE guidelines on RPL, that giving repeated and high doses of immunoglobulins, IVIG, very early in pregnancy may improve the live birth rate in women with 4 or more unexplained recurrent pregnancy loss. However, more trials are needed to study the effect of the IVIG treatment in women with RPL. But it has been shown that some studies have shown it might improve the live birth rate in those with RPL 4 or more which are unexplained. And about the vaginal progesterone, not for recurrent pregnancy loss which is unexplained with 3 or more or 2 or more pregnancy losses, only vaginal progesterone to be considered to improve the live birth rate in women with 3 or more pregnancy losses and vaginal blood loss in subsequent pregnancy, which means if a woman has come with a threatened miscarriage and she has got a previous history of recurrent pregnancy loss, then in this present pregnancy, it is indicated to treat her with vaginal progesterone, as it has shown to improve the live birth rate. And oral dydrogesterone, that is indicated and initiated when the fetal heart action can be confirmed, may be effective, but more trials are needed. That is in cases of threatened miscarriage. If women with recurrent pregnancy loss ask about using multiple vitamins, the supplements, they should be advised on multivitamin supplements which are safe in pregnancy. So those treatment which are not recommended are progesterone definitely not will not improve the live birth rate in those with unexplained pregnancy loss or in luteal phase defect. And the guidelines recommends against the use of progesterone in women with unexplained recurrent pregnancy loss. HCG is not recommended in those with RPL and luteal phase defect. Metformin supplementation to prevent pregnancy loss in women with RPL and glucose metabolism defects not recommended. Only one small RCT has showed that there is no benefit of doing a hysteroscopic septal resection on those women with septate uterus and recurrent pregnancy loss. But earlier it was told that hysteroscopic septal resection might improve the live birth rate in those women who are suffering the subfertility or recurrent pregnancy loss because of septate uterus. But the new guidelines have come with an update that one small RCT showed there was no evidence of benefit. Definitely no other uterine surgeries have been recommended for improving the outcome of recurrent pregnancy loss, like metroplasty for bicorporeal uterus with normal cervix, uterine reconstruction for hemiuterus, metroplasty in women with bicorporeal uterus and double cervix, hysteroscopic removal of submucosal fibroids or endometrial polyps, surgical removal of intramural fibroids, and surgical removal of intrauterine adhesions. All these have not been recommended to improve the pregnancy outcome in RPL. So about the intrauterine hysteroscopic adhesiolysis, after that, again, there will be recurrence of adhesions. So because uterine surgery is known to have recurrence of adhesions again and again. So then we'll have to give treatment to prevent the recurrence of adhesions. So that's why it has shown no benefit to improve the pregnancy outcome. What about the sperm selection by physiological intracytoplasmic sperm injection, the PICSI, in couple, those who have been found to have recurrent pregnancy loss, in order to overcome the risk factor of sperm DNA fragmentation in poor semen quality of male partner. So the sperm, that is also recommended at present by the guidelines. The sperm selection by PICSI leads to significant decrease in pregnancy loss rate in women more than 35 years. It's not on RPL, but more evidence is needed to recommend that this treatment is useful for those with RPL. But in more than 35 years, it was found to improve the pregnancy outcome, but not in those women with RPL. Not recommended to use antioxidants for men, lymphocytic immunization therapy for unexplained recurrent pregnancy loss, and it might even have serious harmful adverse effects. Glucocorticoid management for unexplained RPL or those with selective immunological biomarkers should not be used unless it is indicated for any management of flare conditions of any autoimmune disorders. Heparin low-dose aspirin in unexplained RPL should not be used. Intralipid therapy for improving the live birth rate in unexplained RPL should not be used. Granulocyte colony stimulating factor in women with unexplained RPL not recommended. Endometrial scratching in women with RPL not recommended. So we'll quickly go through a few questions that have been repeatedly asked from this topic. So there are cases of women who have recurrent pregnancy loss. What percentage is contributed to antiphospholipid antibodies? Yes, we discussed it's almost around 10 to 15% of the cases. And coming to about the next one. So a woman attends early pregnancy unit having experienced her second successive miscarriage. She has been researching miscarriage on internet and has read that most miscarriage are due to genetic problems. So the question is simple. What percentage of first trimester miscarriage are due to chromosomal abnormalities? So almost it is found that 50% of all the first trimester miscarriage are because of chromosomal abnormalities of the fetus, and more. Also, in recurrent pregnancy loss, it's mainly contributed by structural chromosomal abnormalities rather than numerical chromosomal abnormalities, because as the number of pregnancy loss increases, the risk of having a numerical chromosomal abnormality reduces, as it occurs mostly sporadically. A 32-year-old woman with history of recurrent miscarriages, antiphospholipid antibodies were tested in her initial visit and it was found to be high. What's your next advice? No, we don't start to advise to start immediate aspirin low molecular weight heparin. Definitely, we need to start repeat the test after 12 weeks and see if it is still positive, because we can even get false positive results with one test. So if we have a satisfied clinical criteria for a lab criteria, we need to do 2 times the blood test. In both times it's found to be positive, it satisfies the lab criteria, and then we can, in the next pregnancy, start preconceptual aspirin and low molecular weight heparin or unfractionated heparin prophylactic dose from the date of urine pregnancy test positive. So that's about the SRI guidelines, the recurrent pregnancy loss. Anybody, any questions? Thank you for your patient listening.